Hi, welcome to Team 3's presentation, The Importance of Establishing Best Practice for Patient Handoffs. Patient handoffs occur each time a provider transfers the responsibility for a patient's care to a new provider. The importance of establishing best practice for patient handoff communication is a serious concern for healthcare organizations. According to the Joint Commission, miscommunication which occurs during the transfer of a patient's care may account for up to 80% of serious medical errors. For this reason, the Joint Commission has required all healthcare providers to implement a standardized approach to handoff communications, including an opportunity to ask and to respond to questions. Team-based care has been a pivotal feature in the improvement of healthcare quality for more than a decade. Team-based care has been identified as a key feature in an organization's pursuit of the triple aim as defined by IHI: improved patient experience, improved population health, and reduced healthcare costs. Additional changes in healthcare also foster the use of team-based care. In 2012, the Patient Protection and Affordable Care Act authorized the use of accountable care organizations, or ACOs, which are a group of providers and suppliers of services, to coordinate patient care in order to deliver seamless, high-quality care for Medicare beneficiaries. The creation and use of ACOs spreads the responsibility for patient care beyond the walls of the hospital or physician's office. The ACO includes primary care providers, specialists, inpatient and outpatient care facilities, post-acute providers, and private companies like Walgreens. The aims of an ACO are to ensure high-quality care and to contain healthcare costs. By reducing errors, such as those caused during patient handoff, both the quality care and cost containment objectives will be supported. As team-based care expands in its use and scope, so does the opportunity for handoff errors. Within the last few years, the Joint Commission revised its area of concern with regard to handoff errors. Rather than limiting the recommendation for improved handoff procedures to hospital-based care, the Joint Commission expanded its quality initiatives beyond the hospital walls. All phases in the transition of patient care involving hospital caregivers are being examined: between caregivers within a healthcare organization, between caregivers of different organizations, and including the transition of patients post-care. Because patient handoffs occur so frequently in healthcare and between every different medical group, it is important that best practices are established and followed to ensure patient safety no matter who is involved in the handoff. The Joint Commission has stated that communication breakdowns during patient handoffs are the single largest source of patient safety threats. As a result, numerous studies of patient handoffs have been completed throughout the healthcare system. Patient handoffs have been examined between various providers and in various facilities in an effort to establish best practices and to provide learning opportunities for everyone involved in patient care. Patient handoffs can occur between providers, between facilities, within hospital units, or at any time a patient's care changes hands. One of the most commonly studied handoffs is between providers at shift change in hospital facilities. These studies include handoffs between physicians, residents, or nurses of the same unit, between providers of different units within a hospital, or between two healthcare facilities. Patient handoffs can be considered the glue that holds a patient's healthcare journey together as their care transitions between multiple providers. Not only is it important that handoff communication takes place, it is important that quality standards for content of handoff communications exist so that the patient's treatment information be communicated completely during transitions in care. In 2006, the Joint Commission identified a national patient safety goal for all hospitals to implement a standardized approach to patient handoff communications, including an opportunity to ask and respond to questions. This goal has remained a priority ever since. One of the most researched and potentially one of the largest gaps in communication in patient handoffs occurs between residents or between a resident and an attending physician at shift change. Various studies have shown that typically there's no formalized education regarding a successful patient handoff. As a result, residents learn handoff procedures on the job, so training may not take place reliably or include best practices for effective and efficient communication techniques. Furthermore, lack of formalized training does not support the residents' need for tools to address barriers in communication, shortchanging both the residents and the patients in their care. Apart from the lack of formalized education, many studies of patient handoffs highlight barriers to communication. One study of handoff practices at the Indiana University School of Medicine examined handoff procedures throughout their internal medicine residency system. The program used 4 hospitals with 3 different computer systems. The study found that each hospital utilized a different handoff procedure. 2 facilities used a standardized computer-generated handoff form in all departments. Another facility had a different handoff form for each specialty. The final hospital allowed residents to document their handoffs either through a handwritten form or a word processor form, allowing varying degrees of quality and usefulness between residents. Through this analysis, the authors found many barriers to an effective handoff within the hospital setting. These barriers included the physical setting for confidentiality and patient privacy concerns, the social setting, referring to the potential for the setting to reinforce status differences between residents and providers with greater authority, language barriers, and finally, the medium of communication used, such as direct interaction, telephone, email, or paper communication. Another study of handoffs between residents in internal medicine, surgery, obstetrics, gynecology, and pediatrics at one hospital found 5 particular attributes of poor handoffs that eventually led to problems for the patients. These attributes included truncated handoffs due to time constraints, diagnostic and other care activities left unfinished at the end of shift, challenging handoffs due to residents not knowing or trusting one another, lower familiarity with patients due to large patient loads, and coordination problems due to the lack of clarity regarding who was responsible for the patient. Each of these contributory factors pose opportunities for learning and process improvement. While many studies have focused on gaps and barriers in patient handoffs involving residents, they are not the only providers to be considered. Studies have shown that all providers, surgeons, attending physicians, nurses, nearly all staff are potentially involved in patient handoffs and need to be considered when looking for improvements and ways to increase patient safety. One of the most important handoffs in the hospital occurs within the operating room. For example, Orange County Kaiser implemented a formal pre-surgical briefing with an inclusive process that engaged multiple staff members and visible physician leadership. The briefing was designed to include information that the surgeons, nurses, and anesthesiology staff wanted to know. Some facilities chose to brief in the OR while the patient was awake, while others chose to do so after the patient was anesthetized. There was a concern that patients would feel that the staff did not know what they were doing if the patients were awake during the briefing. But patients seemed to like the process and felt it showed that everyone was on the same page. The perioperative briefing was successful and not only was found to reduce wrong site surgery, but improved overall staff satisfaction. Nurse turnover dropped by 16%, and the participants noted a significant improvement in teamwork. Patients being discharged from the ICU are particularly vulnerable to poor handoffs given the complexity of their health conditions and the transition to a floor ward with less monitoring. Several studies have identified deficits in communication, coordination of care, and information exchange between the ICU and the ward as factors which may increase the risk for severe adverse events, ICU readmissions, and increased mortality. Ward nurses felt that receiving ICU transfers was stressful and anxiety-provoking. The interaction between nurses during the transfer of patients from the ICU to the ward setting can impact the quality of care that patients receive. Incomplete handoffs can lead to errors in nursing care, medication errors, and reduced monitoring when there is potential for deterioration. One study determined that patients who are transferred back to the ICU from the floor are 11 times more likely to die in the hospital than those who remain on the hospital ward. One American study found that 37.3% of ICU readmissions within 48 hours were preventable. An Australian study found two key themes associated with ICU readmissions: lack of resources on the general wards and lack of communication between the ICU and the ward staff. Though a significant amount of the literature to date focuses on patient handoffs within a single unit at shift change, there are also many challenges when completing patient handoffs between different hospital units. One of the most common areas of concern and a source of many erroneous handoffs occurs between the emergency room and the various other units of the hospital. Patient handoffs in this realm have become known as the gray zone in some facilities because of the ambiguity associated with them. Within the gray area, there are three main categories of concern and confusion. First, there is an uncertainty over the patient's diagnosis in the emergency department. Second, there is a lack of clarity regarding the patient's disposition as they are considered for admission, which is a decision typically made between the physicians in the ER and the inpatient physicians through an inter-service handoff. Finally, there is a period of uncertainty when the patient has been admitted to the hospital and is waiting for an inpatient bed. The question can become, who is responsible for the patient's care? In summary, every time a patient's care is transferred from one service to another, the gray area, there is an opportunity for miscommunication. As we've discussed, transitions of a patient's care are a time of vulnerability. This is especially true when patients are discharged from an acute care hospital to rehabilitation or nursing facilities. Communication failures during this time are typically the result of discharge admission timing. Many of these discharges and admissions occur later in the day, either because of ambulance resources or timing of bed availability. The late timing may result in lack of family presence at the time of admission, leaving the patient alone to answer questions, or may result in the delay in obtaining necessary medications. Patients being discharged from the acute care hospital to an extended care facility tend to have complex medical issues and medication lists. One study suggests the use of two checklists to improve communication handoff upon discharge, one by the discharging physician and the other by the accepting facility. This process offered caregivers the opportunity to clarify discrepancies immediately. Stroke patients are one patient group who are frequently discharged to an extended care facility. Stroke patients are typically complex patients with complex treatment plans and who experience a 3 to 19% readmission rate. Effective handoffs to the admitting facility is important in order to promote secondary stroke prevention by improving communication and knowledge of stroke mechanism and improved medication reconciliation of critical medications, and 2, minimize interruptions of the rehab program by decreasing transfers back to the emergency room or readmission to an acute hospital. Reducing errors in the medication reconciliation is especially important. Stroke patients can be discharged on multiple key medications such as antihypertensives for blood pressure control and anticoagulants to prevent blood clot formation and future strokes. Thorough discharge handoff from the acute care hospital to the admitting facility could help reduce medication delays and errors. Multiple studies also associate adverse events with discharge with a lack of communication between hospital and outpatient providers. Most adverse drug events after discharge result directly from a breakdown in communication between hospital staff and patients or primary care doctors. About 40% of patients are discharged from the hospital with test results still pending, with 10% of those requiring some follow-up intervention. However, patients and primary care doctors may be unaware of these pending tests. Discharge summaries are typically done upon discharge of the patient, but these summaries can lack important information and/or can be failed to be sent to the appropriate outpatient providers. Readmission rates are also found to be higher amongst patients who do not follow up with their outpatient providers within 30 days of discharge. The information supports the need for solidifying the patient handoff communication process between the hospital staff and outpatient providers during the transition of care upon discharge. Our healthcare organizations are being challenged to provide care for patients through improved measures of quality care. Currently, many healthcare organizations have begun to incorporate high reliability standards in their processes, specifically in the areas of safety, communication, efficiency, and education. Thus, these fundamental standards serve as a platform for quality care in any healthcare setting. In support of the improved healthcare quality in hospitals, the Joint Commission identified effective patient handoff communication as a prominent quality improvement initiative. This is further supported by the IHI's triple aim, which emphasized the importance of improving the patient experience. Any incident of inadequate handoff communication is likely to affect both the quality of care, the cost of care, and the patient experience. Therefore, it is important for organizations to work towards highly reliable patient handoffs by improving on best practices. High reliability organizations have implemented various models of standardized handoff communication protocols. The two main tools actively used are SOAP and SBAR. The acronyms serve as a reminder of the elements and the order for quality communication regarding patient care. SOAP stands for Subjective, Objective, Assessment, and Plan. SBAR represents Situation, Background, Assessment, and Recommendations. Using these tools within protocols is an effective way to structure communication between individuals and the units or organizations they represent. When used properly, structured communication can be very effective. However, these tools will only be as effective as the quality of the information they aim to impart. In other words, the breakdown in the system is typically prior to patient handoff or during documentation of information regarding the patient. The importance of having adequate information is key for positive patient outcomes. In 2012, the Joint Commission Center for Transforming Healthcare developed a targeted solutions tool labeled the Handoff Communications TST. The tool was designed to improve handoff communications in healthcare networks by reducing errors and miscommunications amongst healthcare professionals. The tool examines the current handoff communication process from the viewpoints of both the senders and the receivers. Next, it uses a tested and validated measurement system that provides data to organizations that support the need for continuous improvement of handoff communication processes. Furthermore, the system identifies areas of focus, including the specific information needed for the transition being measured. Next, it provides customizable forms for data collection to fit the specific needs of the transition being measured. Lastly, the system provides guidelines to determine the most appropriate and realistic handoff communication process for a given transition while also empowering staff involved in the process. The simple acronym SHARE can be used by organizations to identify areas of weakness and strength in the handoff communication. The S refers to standardized critical content, includes providing details of the patient's medical history to the receiver. Information from separate sources are synthesized before being passed to the receiver. H stands for hardwire within your system, includes developing standardized forms, tools, and methods. It identifies new and existing technologies to help make the handoff successful and states the expectations for conducting a successful handoff. A, allow for the opportunity to ask questions and involves strong communication between the receiver and the sender. Receivers should expect to receive all key information about the patient from the sender. Receivers and senders should also ask questions and exchange contact information in the event that there are any additional questions. R. Reinforce quality and measurement includes demonstrating leadership's commitment to successful handoffs, such as holding staff accountable, monitoring compliance with the use of standardized forms, and using data to determine a systematic approach for improvement. E. Educate and Coach supports organizations providing standardized training to their staff about successful handoffs, providing real-time performance feedback to staff, and making successful handoffs an organizational priority. The TST tool recommends that the organization build a unit team that identifies the project leader and core site team members. Each team member should understand his or her role and responsibilities. A target date should be set, and the organization should first test the tool with a few pilot areas to ensure the results align with the organization's goals. All Joint Commission accreditation facilities have access to this TST tool. According to the Joint Commission, it is estimated that all organizations will see improvements within 16 to 21 weeks. Healthcare delivery systems rely upon information as it influences outcomes. While patient outcomes and safety are factors for high reliability, information transferred between providers needs to be communicated accurately to ensure accountability. Historically, organizations continuously practice this method of communication. However, it now needs to be part of a measured improvement process as we work towards an advanced, unified healthcare system. An effective handoff communication practice is essentially the foundation for an efficient healthcare system as it serves upon the basis of safety. As with any formalized process improvement initiative, several elements are fundamental to its success. Garnering support of the process change by those who perform the process, engaging staff in the analysis and improvement process, providing sufficient education to those affected by the process change, and emphasizing the importance of the improvement goal will all enhance the likelihood of the project's success. In addition, visible support of the process change by leadership, particularly in the conscious creation of a just culture that offers psychological safety and supports a questioning attitude, will greatly enhance the likelihood of positive change. Working toward an improved standard of patient handoff communication and best practices is not an issue for a single facility, but a universal concern. While best practice standards are emphasized, high reliability and value-based organizations will work toward implementing these safe practices. These processes, while improving patient safety, will further add value to the organizations by enhancing trust between patients, their providers, and the facilities they utilize. The importance of clear and complete communication during patient handoff is emphasized by initiatives supported by organizational influence in healthcare quality, such as the Joint Commission and the Institute for Healthcare Improvement. As the use of team-based care expands with the use of accountable care organizations and patient-centered care initiatives, the opportunities for patient handoffs increase. With each instance of patient handoff presents a gray area of increased vulnerability to errors in care. Organizations that recognize this vulnerability as it presents itself both within its walls and beyond will be better poised to address this challenge to patient quality and safety. Thank you for taking the time to view our presentation. We hope the information we have provided will be useful as we work to improve our healthcare system.